Hello everyone, how are you guys out there? I'm hoping that you can see me and that I am horizontal. Can I get a thumbs up if I am horizontal? All right, just gonna try to make sure everything's working with our technology here. And then we're gonna get started talking about essential tremor, a topic that we started a couple weeks ago and had such a wonderful response. We wanted to do a follow-up to make sure that everyone who was out there who had questions had as much knowledge and information available to them as possible. So if anyone is watching and is able to tell me if I'm horizontal, that would let me know if I could get started. Can I get a thumbs up? Okay, does it look like I'm horizontal? Okay, no, we're having another vertical party. Okay, this is how I started my last one, and boy was it fun to figure this out during live television. Okay, well, there we go. Okay, excellent. Let's just take it from here. Okay, hi everybody. My name is Dr. Karen Sullivan. I care for your brain. I am here to try to close that knowledge gap between the way brain health scientists and clinicians think about the brain and what you know as the general public. I'm also here to try to raise awareness and increase compassion and empathy for people who live with brain health challenges. I think that one thing that would make me feel a lot better if I had a brain issue would be information and knowing that I could trust where to get high quality scientific information. And so my commitment to you in this program is to try to bring that to you every Wednesday night at 6 o'clock. I offer local lectures in my community in North Carolina in 2 different retirement communities, but offering this on Facebook is a way for me to get to meet more people and to reach so many of you out there in the world. We've had a wonderful couple of weeks here at I Care for Your Brain. We've had an incredible amount of support, amazing amount of people reaching out from all over the globe, and it's just been so rewarding to be able to connect with you all. So tonight we're going to revisit essential tremor. Like I said, we looked at this a couple weeks ago, but people just had so many good follow-up questions that I wanted to make sure that we got to them. So if you didn't have a chance to see the first lecture that we did, please go back and look at it. It's a lot of the introductory information. So what I'm going to do tonight is get a lot more specific, but let's just make sure that everyone watching is on board. So we know that essential tremor, which we're going to call ET, is a heterogeneous neurological disorder. So what I mean by that is that symptoms vary according to people, and ET, they actually vary according to time of day, according to stress level, according to if you've had some alcohol. There's so many different things that can make the tremors come and go, or the tremors get worse, or their level of disability affect people in different ways, that there's really no real prototypical type of ET. And in fact, a lot of brain scientists think that it's probably not one type of brain disorder, but it probably represents kind of an umbrella term, and there's probably multiple different subtypes within ET. We know that what it causes is involuntary and rhythmic shaking. Most people who have it, I think it's about 90 to 95% of people actually have the symptoms most predominantly in their hands and in their arms, and also in their head. But of course, other people can have voice tremor. About 20% of people have it there, and we think about 10 to 15% of people have it in their legs. It really gets in the way the most when people are going to do things, which of course must make it incredibly frustrating. So things like going to pick up your fork to eat, things like tying your shoes, trying to turn the knob on the radio. It's going in and actually making sure that your fine motor movements are disrupted. That's what ET does to people. So where in the brain does this happen? What we know is that there are really good studies in both the animal and human literature that suggest that a part of the brain called the cerebellum is involved. Now, it's not just the cerebellum in and of its own, because the brain is a very interconnected structure, as I bet you know. So what they think is that there's some connections that go through the cerebellum, another part of the brain called the thalamus, and then also in the gray matter or in the cortex. So the way the brain is set up is there's a lot of what we call reciprocal feedback loops, kind of like big circuits, big rubber bands, whereas if you have a problem in one part of the brain, kind of indirectly it's going to affect another part of the brain. And that's a big part of what we see in essential tremor, is it's not just one type of symptom, it's really not just motor symptoms. And I think that this is what I bring to the table as a neuropsychologist, is validating for people that there are also cognitive symptoms and there are mood and behavior symptoms, and that these things are brain-based. Of course, there are also what we would call psychosocial symptoms in ET, which is basically, it's difficult to live with a chronic medical condition, and it's really difficult to live with one that other people don't understand and misinterpret as maybe being out in the world intoxicated or maybe being a drug addict. I've heard all sorts of heartbreaking things that people with ET have to go through every day because of the lack of knowledge and information. At the end of the lecture, I'm actually going to talk to you about some data, and I think you're going to be shocked that 90 to 95% of people have no idea what ET is. One of the theories there is that it's a movement disorder that doesn't really have a highly publicized figure that is associated with it. Michael J. Fox has done amazing things for Parkinson's disease, and that's wonderful, but the truth is there's not a celebrity or a public person who has been identified as having ET, although we're sure that there is someone out there with it. So that's part of how you spread the word about different types of health conditions, is that someone who is very well known to the public goes out and basically claims it and educates people. Well, we don't have this yet in ET, so maybe this is one of the barriers. But the very best thing that we can do is get together and share this information. So the cerebellum is a very, very important part of ET, and that was a huge thing that I felt like people loved about the first lecture, is that I explained to you what the cerebellum does, because it's not just for motor control and balance, which is a lot of time how it gets stereotyped. So let me first tell you the 10 questions that we're going to go through tonight, and then we're going to get back into the cerebellum. These were questions that I took from people who chimed in on my last lecture, or also from different support groups on Facebook that have been kind enough to let me come in and essentially pick their brains in what I hope is a kind and respectful way about what it is that they live with, because I feel so strongly that that is a critical part of being a good brain health scientist, is that you have to go to the people who are living with these conditions and ask them, what is it that you are challenged with every day? How is it that I can work with you to understand what it is that you are living with every day? So my theory, and I think a lot of good neuropsychologists work this way, is that we are not the only experts in the room, that we are sharing expertise with our patients and our families, and that when we come together, when our academic and clinical knowledge meets their real world experiences, that's how we're going to get to understanding and improvement. So I have been graciously invited into some of these communities, and these 10 questions came up in that context. The first two I'm actually going to collapse together, and they're about cognitive symptoms and what someone called emotional dysregulation, and they're both related to that cerebellar influence, and I'm going to talk about those together. The next one is I had a lot of questions about surgical and non-surgical treatments like DBS, focused ultrasound, and gamma knife. So we're going to go through all of those in detail, and my focus tonight is going to be on the focused ultrasound, because it's kind of the new big thing and people are really, really excited about it, but there are some critical things that we need to talk about that people can understand. We're also going to talk about the meds associated with ET. We're going to talk about changes in lifestyle that people can make. Someone asked me about a certain diet. We're going to talk about internal tremors. We're going to talk about voice tremor and how speech therapists might be able to help with that. And I was also asked the question about non-pharmaceutical interventions like wristbands that you might see advertised on Facebook. So that's going to be our focus tonight. It's a lot. This is not going to be a short lecture. It's kind of funny when people share the lectures, it's happening more and more, and I can kind of see what people write on the top of them. And a lot of people will comment, it's a long one, but if you can hang in there, you're going to learn a lot. Well, I'm just giving you a warning off the bat. Tonight we'll probably be here for probably about 35-40 minutes. But my theory is that you can't learn about things that are as complex and important as the brain in these quick snippets. And in fact, that's one of my criticisms of the so-called brain fitness industry, is that they want you to just think these things can be boiled down to a bullet point or a quick little advertisement blurb. That's not what the public wants. I am convinced that you out there want in-depth, respectful information that is communicated at a level that, yes, you can understand, but is also not dumbed down. This is a crazy thing that's happening out there in the world of brain science, and I am here trying to do my best to offer a different way. So like I said before, let's collapse these cognitive symptoms and the emotional symptoms together. The way the brain works is that there are essentially three systems. There is a physical system, there is a cognitive system, and there is a mood system. And they all come back to very specific parts of the brain. So what I mean by that is that different parts of the brain have jobs in your physical self, your cognitive, your thinking self, and also your emotional self. So whenever there are problems in one system, like essential tremor being a movement disorder, you are also always going to see problems in the cognitive and the emotional system. This is essentially what a neuropsychologist does, is that we try to look behind the scenes, not just at observable behavior. We try to understand how people are living inside their minds, okay? So the cerebellum is a fascinating part of the brain. It's actually one of my favorite parts of the brain, probably because it's kind of misunderstood, and I love the idea of shedding light on things that commonly get talked about in a not so accurate way. But the cerebellum is really the great regulator of the brain. It regulates movements. It regulates fine motor speed and movements in particular, but it also regulates things like language, things like mood and behavior. And it's because of those reciprocal interconnections with another part of the brain, which is the frontal lobes. And that's really a critical thing to understand with ET, is that it's not necessarily a problem in the cerebellum, it's a problem with the entire circuit, with the entire tract, also including the thalamus. And so much of the surgical interventions are connected to the thalamus, but really they're trying to disrupt the problem on the whole entire circuit. So it's really those three different parts of the brain that I want you to think about. The cerebellum used to be thought of as just the balance center of the brain, but due to some work that came out of Mass General Hospital in Boston by a doctor named Jeffrey Schwaman, we have insight into something called the the cerebellar affective cognitive system. The issue there is that the reciprocal connections are related to the word choices that we make, finding specific sounds that go along with the words that we want to use. So this is why sometimes in ET you can have symptoms of what we call dysarthria, which is you know the word you want to say, but either you can't find it as quick as you want to, or maybe the words don't quite come out as clear and as enunciated as you would like them to. This is because that circuit is having difficulty. In terms of the emotional symptoms, the way that it was described to me by different patients is a feeling of being overwhelmed, a feeling that noises, crowds, stress, these things, we just feel like we don't have the capacity for them anymore the more advanced ET gets. And this is really related to that frontal lobe issue. The frontal lobes are the most evolved part of our brain, and they really are involved with the initiation of behavior, but also the stopping of behavior. So the way I describe them to my patients is as your gas pedal and your brake pedal in a very simplified way. And when you have problems in your frontal lobes, either directly from an injury or indirectly, which is the case of ET, there's basically a problem with the starting and the stopping. So think of how much behavior and emotional regulation has to do with starting and stopping emotions. So when someone has had a cerebellar stroke and they come to me, the problem that they'll often tell me is an emotional one, that their emotions seem to come on so strong. People have used the metaphor of like a freight train. just coming out of nowhere, full steam ahead, all of a sudden either anger or even joy or happiness, but that it also goes away almost as quickly as it came. These are the things that we would expect. Just understanding neuroanatomy, you would expect these things in ET, but they don't get as much press, they don't get as much write-up because they're not observable, right? When you read about ET, I mean, even when I was trained, just not that long ago, I shared this with you in the last lecture, I was trained that there were no cognitive symptoms in ET, that it was one of the movement disorders that you would not see any cognitive problems with, and that's just not true. And it's kind of fascinating to me that that would ever even be considered, because when you understand what parts of the brain are involved, and they've known that for quite a few decades now, you should appreciate that you're also going to get other types of symptoms. And when we don't talk about these things or validate these things as doctors, patients are out there thinking that they're crazy or that it's stress and it's depression and anxiety. And of course it can be those things too, and it can exacerbate essential tremor, and you can get problems coming at you from two sides, which of course is going to magnify it and make it worse. But ET in and of itself, it absolutely has cognitive symptoms, it absolutely has emotional symptoms. So what I would expect in ET, like I said before, is some trouble with word finding, some trouble with finding the right sounds, but also just general retrieval, knowing something, knowing you know what it is, but having a little bit more of a hard time finding it, kind of finding the book on the shelf, but also emotional, overwhelming type feelings, and that leading to irritability. I mean, that's just a normal human reaction. That's one thing that I always want to encourage people to think about with brain disorders. People who have a brain disorder are not just their brain disorder. They are also human beings who get ticked off at things and maybe have a history of depression, and they're bringing all of that to the way that they experience their brain disorder. So that's part of what I love about being a neuropsychologist, is that we're trying to be inclusive of the whole person and not just reduce someone down to a diagnosis. The next thing we're going to talk about are these different, after you try medications, the next treatment options that get talked about are things like DBS, focused ultrasound, and gamma knife. So I want to talk to you about those in detail. There really hasn't been that much significant progress in quote unquote the non-surgical side of ET in the last few decades. There really, there's one medication that is FDA approved. But on the other hand, the surgical side of ET has been very, very active, and there's been a lot of advances in this area. So there's really three different modalities that are used for ET at this time, and that's deep brain stimulation. There is ablation, which is what gamma knife and high frequency magnetic resonance guided focused ultrasound is. And there's also non-invasive, which are things like transcranial magnetic stimulation. I'm not going to be talking about the third one. We're really going to be talking about DBS and gamma knife and focused ultrasound. Within the ablation techniques, you can either have what they call invasive or non-invasive, and the two that we're going to focus on, the gamma knife and the ultrasound, are considered to be non-invasive. So let's start with DBS. What is DBS? It is a stereotactic brain lesioning system that has been used for decades and is very well established as an effective treatment for what we consider to be medically refractory patients. These are people that are not getting as much oomph out of their medications anymore, which is often the case in Parkinson's disease. A lot of those medications have a lot of power when they come out of the gate, but unfortunately over time they lose their efficacy. Also, some people are completely medication intolerant. They just can't stand the side effects, so they literally can't get any relief, and so you start to think about a little bit more invasive techniques. Older surgeries, I mean, they've been doing brain lesioning and movement disorders for a pretty long time, but they used to actually have to create a hole in the skull and go in, and they did basically burning of different cells in areas like the globus pallidus and the thalamus. But of course these were very invasive, and you had a lot of damage that wasn't anticipated because you weren't able to really be focal and to really get into the specific area. So with DBS, What we know is that it's very, very, very specific. And this is why part of the workup is these very detailed MRIs of the brain. So your neurosurgeon and your neurologist have this really, really clear picture that they use as a guide when they're putting in the thin wires called electrodes into either one or both sides of different subcortical structures in the brain that control movement. In essential tremor, what they're going after is something called VIM, which is the ventral intermediary nucleus of the thalamus, and often it's referred to as the VIM loop. So remember, it's not that they're going into the part of the brain that is specifically problematic in ET, but what they're doing is basically getting into the circuit. It's kind of like an access point, and we're trying to affect the whole entire circuit of the loop. Once the electrodes are situated during a DBS surgery, which is awake at this time, there are some medical centers that are kind of flirting with the idea of putting people under, but being awake is actually something that's important to know, because that can be a barrier for some people. Many people, I do pre-neuropsychological DBS evaluations for UNC Medical Center up the road here in North Carolina, and one of the questions that I'm asked in my evaluation is, can this person handle being awake during brain surgery? For some people it doesn't bother them at all, but for other people it really freaks them out. The idea of being awake, it's just too scary. It causes too much anxiety. That is something that you can actually work on with psychologists, try to become a little bit desensitized, but it is something that happens awake. So after the electrodes are situated, they get connected to something called a neuromodulator, which in a later surgery is implanted under the chest wall. They then connect them a few weeks later. You go to see your movement disorder specialist, and they basically use a handheld programmer to set the parameters which are targeted to each individual person. There's no one setting that's going to help each individual person. These settings are tweaked over time, and the goal is not to completely, well, not the goal, I should say, the realistic outcome that you can expect is that symptoms will get better and that you'll have to use less medication. But this is not a cure, unfortunately. People still have to take meds that give them side effects. Hopefully it's less, but they do hopefully get some relief. The idea with DBS is that you get relief over some and not all of the symptoms. Typically the symptoms that medication help to bring down, you can also expect to get some relief during a DBS treatment for that. Now, I'm bringing up Parkinson's in this talk because DBS started out, of course, most commonly with patients with PD, but it has absolutely been used quite a bit in ET. So determining the perfect parameters or the setting on the DBS neuromodulator typically takes about a year. So it's a lot of back and forth with your provider. It's not a magic cure. The battery has to be changed about maybe once every 3 to 6 years. And it can be reversed. That's actually very important to know. In fact, the 20th anniversary of Medtronic getting FDA approval to do the one-sided thalamic DBS stimulation is happening this month. So that's pretty exciting. A general rule with DBS is that you cannot have Parkinson's disease dementia when you get it. Typically, frank dementia associated with essential tremor doesn't happen, but of course there is something called a mixed dementia where you can unfortunately have more than one brain condition. So somebody can actually have the beginning stages of Alzheimer's, for example, and essential tremor. So it is contraindicated in those patients. So it's not for everyone. You have to go through a pretty detailed workup prior. Now let's talk about focused ultrasound. This is kind of all the rage, and brain scientists are a little worried that patients are getting a little bit too hopped up on it because it kind of sounds too good to be true when it's really so new that we don't have a lot of answers about the long-term outcome. So let's just describe it a little bit more. It is a non-invasive, incisionless procedure that ablates or kills deep tissue in the brain. The therapeutic effects are immediate. It's performed on an outpatient basis. There's minimal discomfort and few complications when you go, of course, to a well-trained group of clinicians. And so the idea is that it allows for a more rapid recovery. There's no risk of infection because you're not actually opening up the brain. and there's no radiation, so that's something that people can appreciate. There is no general anesthesia that is used for it. It is a local anesthesia, and part of what has happened is that people are kind of starting to talk about it almost like a cure-all or a wonder drug, and it's really just not. One of the barriers has been cost, and only very, very recently has it actually become approved by CMS, which is the regulating body for Medicare and Medicaid, and I'm going to talk to you about that in a little bit. And that's really exciting because we do want this to be available to appropriate patients. It's just that it's not a magic pill. And again, that's kind of one of my my reasons for being here and doing this program with you, is that unfortunately magic cures and quick fixes and pills and supplements, those things really don't exist when it comes to brain health. The brain is much too complex to be able to be completely restored to health with one little element. Brain health is always going to come to you from multiple different avenues coming together. So focused ultrasound is the marriage of two different innovative technologies coming together. It is either MRI imaging or what we call ultrasound imaging, basically giving us the target that we want to go in and use the high focused ultrasound technology to be able to get in there. And what it's really using is something called thermal energy. And I'm going to explain to you how it works because I think it's important that you know that. High intensity focused ultrasound has actually been around since about the 1940s, and it's been used for a variety of things. I mean, this is a part of the technology that gets rid of cataracts. They've used it to get rid of a variety of benign and malignant tumors, things like uterine fibroids, breast cancer, even bone metastases. They've also used it to accelerate fracture repair after someone breaks a bone. But it really wasn't until maybe 1960 that a group of scientists called the Fry brothers started to try to ablate brain tissue. And the first time they did this, they actually used patients with PD, and like I was saying to you before, they actually had to remove part of the skull. So that's very, very invasive. But what happened a couple decades later when they started to discover levodopa and DBS, the use of ultrasound kind of faded away, and in the 1990s when MRI technology came out, a couple of really smart people started to think, maybe they were onto something. Let's bring this back from the past and see if we can find a new application. But it was not until July 2016 that the FDA finally approved unilateral unilateral focused ultrasound for what they consider to be refractory essential tremor. And what this is for people who are not getting relief from medications. So since that time, the research has just basically been exploding. And it was a little overwhelming for me to try to look in the last week about, okay, I need to understand what this is, what are the risks, how do I explain this to people? There's a whole lot of research out there. So what I'm trying to do is kind of condense it to you, give it to you in this nice little packet, this little Christmas present. So one of my first questions was, well, why did this take so long? And one of the big problems was that it was very difficult to get the ultrasound energy through the skull. The skull is actually this really thick barrier that is really difficult to actually get through without causing burns to the skin and to the skull. So it actually took a lot of time for someone to develop a helmet, a multi-element helmet that could keep out the bad energy but also let in this focused thermal energy that could do the therapeutic work. So the way it works, the best metaphor that I read was to basically think about it like a magnifying glass that is focusing beams of sunlight on a single point to burn a hole in a leaf. That is an excellent description of focused ultrasound. So the idea is one of these beams wouldn't really do anything in and of itself. It wouldn't be strong enough, wouldn't be hot enough. But when you get a bunch of beams coming in together and you're able to focus in on a specific part of the brain, what you're actually going to get is cell death. And the specific type of cell death, they call it with focused ultrasound, is called coagulative necrosis. Now this can of course happen through traumatic brain injury, through stroke. It's basically a dying of brain cells due to starving them, giving them a lack of oxygen, or also creating so much cell death byproduct that they basically suffocate and can't live anymore, and then they die. This can happen through trauma and accident, or it can happen intentionally, as in the case of modern medicine. But what's really interesting to me is that depending on the intensity of the heat that you apply in focused ultrasound, you can actually achieve different therapeutic goals. So when you do low intensity, what you can do is actually affect the functioning of the cells, and you can use this for something called neuromodulation. We can talk about that another day. That's not really relevant to what we're talking about today. When you increase the heat a little bit to what they consider to be moderate levels of energy, you can actually safely open the blood-brain barrier, which is amazing and very, very important to things like brain tumor, because when it's closed, it's a very tight cellular junction, and the idea is that very few things should be able to get through, and that's a protection that evolution has given us, because we don't want toxins going up to the most important part of our body, right? But if you can therapeutically open it for a few moments and get very strong, powerful medications to the brain, this would be an amazing breakthrough. When ultrasound goes up to what they call high energy, which is over 44 degrees Celsius, then we can actually create a lesion in the brain, and this is where we get the benefits for essential tremor. It is only allowed to be done unilaterally, so this means only on one side of the brain structure. Everything in the brain is redundant. There is one copy of everything in the left, and there's one copy of everything in the right, and there's some structures that connect us right down the middle. But for the most part, we basically have everything in duplicate. And so what is allowed with focused ultrasound and ET is that you're only allowed to do it on one side. So you can use your reasoning to figure out, where is someone going to get symptom relief? They're not going to get it in both hands. They're going to get it in one hand, which is going to be opposite to the area where they made the lesion. The data that the FDA relied on to agree that focused ultrasound was safe and effective was through a product called X-Ablate Neuro. And what they did is they looked at 76 patients who had essential tremor, who had not responded to medication therapy. 56 of them were randomly chosen to receive focused ultrasound, and 20 of them received a fake treatment initially. But based on the ethics that we all have to abide by with internal review committees, they had to offer the patients the actual treatment. I think it was 3 months down the road, which is of course right in the way it should be. But the folks who actually got the focused ultrasound showed a nearly 50% improvement in their tremors 3 months after the fact compared with their baseline tremors. And patients in the control group showed no improvement whatsoever. At 12 months post-procedure, the treatment group retained 40% of their improvement, which is pretty impressive. So what would actually happen if you out there with ET were to go in and to get focused ultrasound? I wanted to kind of paint you a picture to give you a visual on what that might be like. So the idea is, before the surgery, you get a CT scan of the entire skull, and the idea is that they're actually measuring your skull thickness, because this is one of the reasons that might prevent people from getting focused ultrasound, is their skull is too thick and the ultrasound cannot penetrate. Most people have, kind of an average amount of skull thickness, so that's the first thing that they have to do. On the day of treatment, a frame is fixed to a shaved part of the person's head under local anesthesia. And at the same time, they look at the scalp to make sure that there's no scars or anything that could impede the passage of the ultrasound into the brain. An elastic diaphragm is then filled with cooled water, which is attached to the scalp and is connected to what they call the transducer, which is basically how the ultrasound beams get from the machine into the person's brain. It is done without sedatives because they need feedback from the person. This is actually very similar to DBS. They need feedback from the person. Is this working or not? Let me see your tremor. We want to actually monitor you and see how much relief that you're getting. What they actually do is slowly increase what they call the sonications, which is the temperature degree. Remember, we have to be above about 40-45 degrees Celsius for this thing to work. And they want to make sure that they're in the right location. So they kind of go up, 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 up until they get the result that they want. It takes about 3 to 4 hours. And following the procedure, people go into a recovery room, and post-MRI images are taken of their brain to actually look at the lesion location and the size. They do a lot of observation. In addition to the MRI, they do a lot of observation, asking people to hold their hands steady, to hold specialized monitors so that they can make sure that the tremor has reduced. But there's also a very lo-fi thing that they do to assess tremor relief. And I wanted to talk to you about it quickly because it's one of those cool things that when you know about it, you can actually do it yourself at home to figure out if a medication is working good for you, to figure out what time of day your tremors are worse. So much of having a brain health challenge is figuring out yourself and then finding good doctors who care and want to hear what it is that you're living with so they can help you. And it's called spiral drawing. I love lo-fi, simple, paper and pencil things that you can do that are actually very sophisticated and a window into the brain. So just having someone draw a spiral, this is actually used in very prestigious academic centers to judge the success of things like focused ultrasound. The problem we have, not to be a bummer here, but focused ultrasound has a lot of unknowns. There are side effects, and for quite some time it was frankly inaccessible to people. I'm going to tell you the cost in a minute, and I don't know about you, but there's no way that I could have afforded it. There are a lot of people that think it's risk-free, and that's just not the case. There are variable effects on people. It's not a home run, great result for everyone. There can be what we call a hyper response to brain tissue that is damaged, and you might get unintended symptoms that even the very best doctors in the world could not have anticipated. As I said before, they can only do it on one side of the brain, so the relief is only going to be one-sided. Adverse events include things like numbness, tingling of the fingers, headache, imbalance, unsteadiness, and maybe a little bit more difficulty with gait. We also know that there's people who can't get it. So if you have anything that makes you unable to get an MRI, you really aren't a candidate for focused ultrasound. So this is any kind of implanted metallic device, such as a cardiac pacemaker. If you're allergic to the contrast dyes that they give you in MRI, you really can't get it. And maybe most importantly, if you are taking drugs that are known to increase the risk of hemorrhage, you are ineligible, because remember when I said it's basically getting in there and causing a little bit of brain damage. And so what does the brain do when it's damaged? It bleeds like any other tissue in the body. And so if you have thin blood and you're someone who has a tendency to bleed, they're going to be relatively resistant to doing this. And of course that increased skull thickness that I was telling you about before. The unknowns are that the long-term effects are not understood. This is just something that's been FDA approved for about a year. So we really don't know. We don't know if someone's tremor does come back. Can we go in and do another ablation in that same area? So we don't know if people are eligible to get 2 focused ultrasounds. There are safety concerns about doing bilateral approaches, which would mean more symptom relief bilaterally in both hands. We don't know because it's only approved to happen on one side of the brain. We also don't know if over long periods of time the effect wears off. One thing that is really interesting for me in focused ultrasound is that there is a very impressive placebo effect. So in that research I was telling you about before, 22% of the people who didn't get it reported that they were better, had less tremor, but when you actually did physiological tests on them, their tremor hadn't actually changed. So this is something I've talked about in other lectures. The placebo effect is just super, super powerful. There's also the nocebo effect, which is basically if you think something's not going to work, you're giving it a much greater chance of actually not working. But these things are just important to know, and basically I just want to raise concerns because I think so many people just think it's kind of the end-all be-all, and it's wonderful and it's important and it's powerful, but it's just not necessarily going to be the best result for everyone. So in November 2016, CMS, which is the regulatory body that approves procedures and sets reimbursement prices for Medicare and Medicaid, decided to reimburse for the X-ablate neurosystem for essential tremor. And this was wonderful, but the reimbursement rate was actually very low. Prior to any insurance paying for it, it would cost you between $25,000 and $35,000 for a session of focused ultrasound, making it only accessible to very wealthy people, which of course is totally wrong. Beginning in January 2018, they're actually allowing for a much higher level of reimbursement. So when they first approved it in 16, it was $9,751. They're increasing it to $17,500.50. And this is really exciting because CMS basically sets the rules for all the other insurance companies. What they do, Blue Cross Blue Shield, Aetna, all these other places, they basically look to them as the almighty mother making the rules, and they will say, okay, we will now follow suit. So when CMS or Medicare does something, we all get really excited because that means other places are going to follow suit. However, there is one caveat, which is that CMS doesn't make the rules for the whole country. So I'm talking about the US now. There are regional offices that have to make approvals too. So for example, me in Central North Carolina, we have a CMS that basically makes rules for North Carolina, South Carolina, and some other areas around here. So what is okay for me here might not be okay for somebody up in Boston. So you have to make sure that you check with your providers and in your specific area. So MDs, of course, are very happy about the increase in reimbursement, and that's why you're going to see it be offered much more widely. It used to be that you would have to go to an academic medical center that was fairly prestigious to be able to get it, and the idea is that hopefully now it's more accessible. So let's talk about Gamma Knife. Gamma Knife is basically the final frontier for people who aren't really eligible for DBS or for focused ultrasound for a variety of reasons. Typically, these are people with advanced cardiac disease, people who are particularly older, people who are called non-compliant, which basically means they won't take their meds. The idea is that if you are medication intolerable, maybe Gamma Knife, which is another way to ablate brain cells to get in there and damage them in a way that's going to reduce symptoms, it would be helpful. So let's talk a little bit more about meds in essential tremor. I told you this one was going to be long. Okay, so drug therapy is the first line of therapy for people who have ET. And the idea is that you start treatment when the symptoms begin to interfere with your daily activities or when the social aspect of having ET gets to be too much for people. The response to various drug therapies is very individual. Almost 50% of people don't actually get relief from medications, which is really concerning. The FDA has only approved one medication for ET, and that is propranolol, which is a beta blocker. It's also used to treat high blood pressure. After that, the next most common med is primidone, and this is an anticonvulsant. These are considered to be the first line agents. Once you get through the first line, then you move on to the second and third line. And these are things like other beta blockers like atenolol, other types of anti-seizure meds like Topamax, gabapentin, and sometimes what we call benzodiazepines, which is like Xanax and alprazolam and these kind of things. There's also other kind of off-label uses, Keppra, Ativan, Klonopin, Remeron, but these things kind of, when someone doesn't do well with the first line, you kind of start to make grabs here. People also do use Botox specifically for head and voice tremors. It occasionally has been used in the hand and in the arm, and it's injected into muscles in very small doses, and the idea is it interrupts the nerve messages getting back and forth. This is kind of rapid fire info coming at you tonight, but I want to just get it all out there. So what changes can you make in lifestyle to ease ET? I'm going to talk about two different things. One is other people, and one is something you can do, which is diet. So how about I start first? I'm going to start with the other people thing. The first thing is to surround yourself with people that are either knowledgeable about ET or are interested in becoming knowledgeable about ET. There was a study that came out in 2016 that showed between 85 and 90% of people say they've never heard of ET. I bring this up as a lifestyle change because stress exacerbates ET. Being misunderstood, being misinterpreted. This would cause any human being distress, okay? What they did in this study is they even asked Parkinson's patients if they had heard of ET because, hey, they have a movement disorder, they have tremor, let's see what they know. And only 32.7% of them said that they had ever heard about it. And even in the minority of people who said that they knew it, 10% of these people couldn't name a primary symptom. A third of them couldn't tell you the difference between ET and PD. A quarter of them thought that ET was just related to age. 2/3 thought that it was related to alcohol abuse. Only a third knew that you could get DBS for ET. And 3/4 of them said that they didn't know anyone who actually had ET. So that is a huge opportunity for a lifestyle change, and sharing this video and helping people understand what it is you live with would be a great start, I think, because the more people understand, the more support you can surround yourself with. Okay, let's talk about diet. There is no specific ET diet. The thing that they think helps is if you have a specific food allergy or a sensitivity, then of course you should eat that way. So if you are gluten intolerant, you should be eating that way, but that's got nothing to do with your ET. We do know that cutting out alcohol definitely helps. We know that a little bit of alcohol actually helps. You do want to make sure though that your vitamin B12 and your vitamin D are good, because those can cause tremor in and of themselves, and then you could be getting kind of double tremor, which would of course make it be worse. The only diet that has any science behind it in ET, and it's a very kind of loose association study, is the Mediterranean diet. And there's one in particular called the MIND diet, which is the Mediterranean Intervention for Neurodegenerative Delay. And what they found basically is that the more you ate this certain diet, the less likely you were to develop ET. So it's very correlational, not a very strong scientific basis, but the idea is that it's an anti-inflammatory diet, which is going to be good for your cardiovascular health anyway, so probably a good idea. MIND diets, you can look that one up. Some people, now I didn't read about this in the scientific literature, but some people do tell me, people living with ET, that when they avoid what they call nightshades, they feel a lot better. So these are foods like potatoes, eggplant, peppers, tomato, and the idea is that in some people they cause a big inflammatory response, and some people really feel strongly that this makes their tremors worse. So you might want to think about that. Next question was, can a speech therapist help you make any progress with voice tremor? Oh my goodness, yes, 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 yes. If you have a movement disorder, you need to understand about loud therapy, okay? We call it LSVT, loud treatment, and it came from a speech therapist named Mrs. Lee Silverman in 1987, and it's been studied for about 20 years. It's had support from every federal foundation, and the idea is that it uses the power of neuroplasticity through repetition, getting you to do something new over and over and over again, but it also uses intention. So the idea is that PD, things like different movement disorders, can make things a little bit more small, and the idea of loud is to basically try to overcompensate, so you wind up somewhere in the middle. We commonly think of it as related to PD only, but it can really, really help with voice tremor and essential tremor. About 40% of people we think with ET do have kind of what they consider to be, it's like almost like a exaggerated singer's vibrato kind of going back and forth here, except that it occurs during speech, of course, in addition to singing. So the idea is it's kind of a quivering up and down, and of course this really embarrasses people, and what I care about as a psychologist is maybe does it make people isolated and not want to go out and are embarrassed to talk, which then you can become depressed, and now we've got another problem. So the way loud works is you have to do it for 16 sessions in a single month, and the idea is that it's intensive and it's that repetition that's actually going to get in there and change those brain cells. I then had a question about these wristbands for improving hand tremor. And I gotta tell you, I'm a little bit cautious, a little bit skeptical, because when I went to all of the scientific journals that I trust and are reputable, there's nothing out there. There are a couple patent applications and people give their own science and they try to provide some of their own data, but let's face it, how objective is that when you're trying to make the case for your product? It's one of those things that I think there's a lot more kind of social media awareness and facts being given and not much science, and those things scare me because I get worried that people are going to spend their good money and have hope that something's going to work, and I don't really see any science behind it. I'm open-minded. I think there's some reasons why it might work, but I just didn't see anything. What the science will tell you is the most powerful thing besides meds and surgery that you can do is stress reduction for essential tremor. That might be a great topic for a future lecture. And what I would like to talk about is that so much of our stress is interpersonal, which is the idea that other people are what the problem is in many instances. And a lot of stress management comes down to assertiveness training, which is basically feeling like you have a right to say what you want to happen to you, and you have a right to say that you don't want certain things to happen to you. But that's hard for a lot of us. We get brought up in families where that is difficult and we haven't had it modeled. It's hard for us as women. It's hard for us as older people. It's loaded with problems, but you can absolutely do it. The last thing that I wanted to talk about is these internal tremors. And this was another area that I was really shocked that there was not more scientific research. So I wanted to talk about it, but I kind of have to depend on you guys for feedback if I'm getting it right. So the idea is that the internal tremors are caused by the exact same thing that causes the external tremors. And the way that people describe it is kind of like internal white noise, or like a low-grade electricity that is running through them. Or someone also said to me, imagine if you swallowed your cell phone and it went on vibrate. That's how it would feel. What is hard to hear about these symptoms that people feel like they're going crazy, and that must be because there's not a lot of research, so a lot of doctors and scientists don't really validate it. They don't really think it's a real thing, but too many people talk about it for it to not be a real thing. We also know that there is research on internal tremors in Parkinson's disease, and although they are two distinct movement disorders, there also is some general similarities. So if you look at PD, 44% of people are going to tell you that they have internal tremors. 6% of people in the quote-unquote normal, whatever that means, population will also tell you that they have them. There was only one study that I could find that was in a journal called Parkinsonianism and Related Disorders in October 2013 that just asked about internal tremors. Didn't explore them, just asked. And 55% of people with ET said that they do experience them. The thing that is helpful, that we know through clinical experience, is intensive exercise and making sure, like I said before, that your basic vitamin levels are good, vitamin B12 and vitamin D particularly. This was an idea I had that I wanted to share because I know it bothers some of you so much, and I wanted to try to come up with anything that would be helpful. It really made me think about some of the basic things that I learned early on in my training about the mind and body connection and how they're so intertwined. One of the bodies of research that initially got me interested in psychology is by a Harvard psychologist named William James. He's very famous, and basically he met up with this physiologist named Carl Lang, and they came up with the James Lang theory of emotions. And basically the idea is that physiological things happen in your body, and then your mind labels it as being attributable to something, and then you have the emotion, right? So the idea is that they would say is that you see a bear and you start to tremble inside because you're afraid of the bear. Your mind then, your brain, interprets the trembling and says you must be anxious because you're having this trembling, which is the pattern that I associate with anxiety. The idea is that something internal or external basically prompts a label from our emotional system, and that's what tells us how we feel. Now, of course, this happens in a split millisecond and it's all unconscious. But think about how that might relate to tremor disorders. we know that people with tremor disorders have a lot more depression and anxiety than people with other type of health conditions. And of course, a huge part of that is actually brain-based. But, you know, we're also social creatures and psychological creatures. So it also must be the case that we have some type of thought control over our symptoms that can either just in a very small way make it better or worse. So if you're having internal tremors and a thought that you're having anywhere in your mind is, no one can figure this out. This must mean that I'm going crazy. This is never going to stop. I'm so scared that this is going to get worse. That is going to contribute to the problem. Now, I always need to make sure you understand that I don't presume to know what it is you're feeling. I respect that I am a doctor sitting here that does not have essential tremor. So you can tell me you're out of your mind, you don't know what you're talking about. But there are these tools of psychology that if you understand, you can apply them to yourself and maybe improve your tremors and improve your quality of life. So the idea would be to say more reassuring things to yourself. Like, I know this feels like anxiety, but I'm not anxious right now. This is an internal tremor. I know that this is a real thing that I'm living with. Even though my doctors don't see it, they don't understand it, they don't believe it, I know myself that this is real, and this is just another one of the symptoms that I'm having with my essential tremor. It's really important that you sit quiet and think and listen to the self-talk that you were doing about your tremors and try to think about, is there a kinder, more calming way that you can maybe explain these symptoms to yourself that will in some small way just make them more manageable. That was a lot of talking today, but I hope that you are listening. I hope that this helps. I hope that you can share it with people in your life that can then understand you better. I'm so privileged to be here with you. I am just tickled pink that we're growing like this and have so many new friends from all across the world. Thank you guys so much for your attention. I'm starting to really get excited about the new year and thinking of all the fascinating and important topics that we could be talking about here. I have so many different brain health things that I want to talk to you about, but I also want to know what it is you want to know. So please write in the comment section here about anything at all you would like me to talk about in 2018. I'm taking orders, okay? Some of the things that are on my calendar for the next couple weeks are multiple sclerosis. I think we should talk about lupus. We have to talk about seizure disorders. We should be talking about delirium. If you look back in my archives, I do have some older talks in there before we kind of became popular, the popular kid here, about sleep apnea and stress and free memory strategies. So feel free to go through the archives. But thank you guys again so much and have a good night. Take care. Bye-bye.